Good morning, everyone. Thank you for joining us on this Monday morning. We'll begin today's presentation and then Dr. Shushma will join in. Today, we have an interesting topic about integration of palliative care in an ICU, presented by the team from PMH Mumbai. I would like to invite Dr. Chaita to please introduce our speaker and moderator for the group.
Hello, good morning, everyone. Thank you for joining in. So we have this topic presentation by Dr. Ashwini Bundhe, who is now in her second year of MD Palliative Medicine. She is interested in different areas that you can see, end-of-life care and focus. And she's just in the postings, outside posting, and she's presenting from a double emergency in medicine today. So thank you, Ashwini, for doing this. And I'm sure you've had two busy days, Saturday and Sunday. So all the best to you. To moderate the session, we have Dr. Raghu S Thota, who is a professor in Department of Palliative Medicine at Tata Hospital. He has a good experience of anesthesia. He's an expert in pain management and interventional pain management, and his real area of interest is focus, and he's working, and we're all working very hard to get that into our department. His other achievements you can see on the slide there, and he will be moderating this session. So over to you, Dr. Ashwini and Dr. Raghu.
Good morning, everyone. And greetings from Tata Memorial Hospital Department of Palliative Medicine, and wishing you all Shobha Deepavali. So today's topic will be presented by our second year resident, Dr. Ashwini, as already introduced by Dr. Chaita. And yes, the topic is a very interesting topic, and this is the USP of palliative physician, I will say that. And really, it's very important to integrate our palliative care services into the intensive care medicine, because what I feel is that is the place where most of the patients, if you see the literature, many of the patients, almost 20%, the patients die, and we really don't have a good symptom management, a good family support, a good caretaker support. So we really need our expertise, or the patients and the caretakers need, and the ICU specialists need the expertise of palliative care services. And that is what we are going to try to explain today in today's talk, about how to do and what to do, what is the status of our integration of palliative care services and ICU in today's world and in our country in India. So over to you, Ashwini.
Thank you, sir. Good morning, everyone. Today's topic is integration of palliative care in ICU. And I am as introduced, Dr. Ashwini, second year resident in Tata Memorial Hospital, Mumbai. So today we'll be seeing introduction, the whys, triggers for referral, scope of issue, symptom management, organizational issues, practical issues and barriers, dealing with conflicts, transitioning to comfort care and foregoing intensive care life support at the bedside of the imminently dying patient, the impact of palliative care, today's scenario, and conclusion. So irrespective of disease characteristics, several factors characterize patients in the settings of ICU as well as in palliative care units. So what are these? Mostly the immediate prognosis is often uncertain. The risk of mortality is high. They are fragile. The have to undergo unpleasant invasive procedures in ICUs. They are in pain. They're highly dependent. There's discomfort. And the family members, they are under duress and are required to be involved in decision-making processes. Under these circumstances, palliative care principles are critical in the relief of patients' distress, communication with family members, and in management of patients who are not responding to life-saving approaches. As intensive care unit is not a homogeneous concept or reality. For example, surgical ICUs, they are influenced by a covenantal-like relationship, which means between the surgeon and the patient, it is characterized by a sense of obligation to protect the patient during the surgery and its aftermath, and exaggerated sense of accountability for the patient's outcome. In trauma ICUs, it is characterized by a disproportionately large number of relatively young patients, often without pre-existing medical problems, but with sudden onset of acute life-threatening catastrophic injuries. In neurological or neurosurgical ICUs, they're characterized by patients at risk of physiological survival despite vastly compromised neurological function. So, the inception of intensive care unit, end-of-life care, has always been delivered in this setting due to high severity of illness of the patients. But the concept of palliative care in the ICU did not emerge until the late 1990s or early 2000s, perhaps because the earlier years of intensive care were more focused on physiological support and because patients' family members were often excluded from the ICU. So, despite the technological advancement and critical care expertise available, the death rate in ICU is still as high as 18.1%. So, when the organ functions deteriorate, goals of care are not fulfilled, and life-sustaining treatments becomes a burden on both patient and caregivers, then it is the responsibility of the physician to provide a dignified end to life, control the symptoms of the patient, and provide psychological support to the family members. So, why patients in the ICU are referred to the palliative care? For the clarification of goals of care, 71.2% of the time, 27.9% of the times for discharge planning, then 16.5% of the time for pain and symptom management, 8.2% of time for family support, and also sometimes for supporting death and dignity. So this it was according to the paper given in 2017 by Seaman and Jennifer B. et al. So for patterns of palliative care service consultation in a sample of critically ill ICU patients at high risk of dying. So why is the delivery of palliative care different in the intensive care unit compared to other locations? Because of the professional culture. There are several distinct characteristics of intensive care. The training, like the training of the ICU physicians and nurses, is traditionally directed at life support. ICU staff, there's a professional culture promoting primarily of saving lives. There's always an uncertainty in almost every decision involves uncertainty and inability to accurately predict outcomes for the individual patient. As yet, there are no algorithms to identify patients who would benefit most. So to continue or forego multiple intensive care interventions, such decisions are influenced by both medical criteria, non-medical criteria. Medical criteria, example, need for ventilatory and or hemodynamic support, or the likelihood of survival and morbidity. In non-medical criteria, they include patient wishes, values, goals, cultural and religious beliefs. Because of the complexity of the situation, the weight given to each criteria differs from case to case. And then also there comes time course. Like the typical course of intensive care admission is within hours or days of initial presentation. So which gives patients and relatives little time to adjust to changes in life expectancy, which often limits their ability to discuss with the ICU staff their values, goals, or treatment preferences. Then there's environment, which is patients are often in a shared room and are attached to multiple devices. The patient or their family are acutely aware that some of these are life support devices like mechanical ventilator, continuous dialysis machine, infusions of vasoactive drugs. Accidental disconnection from these devices creates a terrifying threat, as this may result in rapid deterioration and death. Environment is always noisy. Room is often illuminated 24 hours. Families are often struck by the markedly changed appearance of the patient due to his or her medical condition. Access to the bedside may be limited by stringent visiting hours or isolation measures. In patient communication, most patients are not able to participate in discussion because of their illness or sedation. It is common in elderly patients who may have suffered from auditory and visual deficit even before admission. And sometimes patients have speech limitations due to lack of dangers, prior neurological deficits, or even shortness of breath. So, intensive care is very costly, and ICU beds are a scarce resource. Staff and family are always aware that the patient is consuming an expensive resource, and there may be pressure to transfer the patient to a less intense environment. Inappropriate treatment, what is that? So a care that involves the use of considerable resources without any reasonable hope that the patient will recover to a state of relative independence or inability to interact with the environment. So if there's inappropriate treatment, then we can consider shifting the patient. So coming to the according to the IPAL ICU project, Center to Advanced Palliative Care, there are 3 types of triggers for referral. So it is disease directed, then it is, utilization criteria and other criteria. So disease criteria, if the chronic incurable life-limiting illness like advanced cancer, advanced dementia, COPD Gold 4, congestive heart failure stage D, if specific acute illnesses like hypoxic ischemic encephalopathy, traumatic brain injury, intracranial hemorrhage, major infarcts with poor neurological outcome, in multi-organ failure, in persistent multi-drug resistant infections, overall poor prognosis as determined by the physician, significant medical comorbidities with poor functional status. These were disease criteria. Then in utilization criteria, there comes ICU stay over 5 to 14 days, where hospitalization is more than or equal to 30 days, that is chronic critical illness, or if more than 1 hospital admission for the same condition in the last 3 months, or more than 1 ICU admission in the same hospital stay, and when initiating procedures like tracheostomy, hemodialysis, PEG in patients with life-limiting illnesses. In other criteria, complex physical psychosocial issues, frailty, CFS score more than 7, family requests, conflict, advanced directives for palliative care, there's poor social support, or more than age is more than 80 years. So a paper by Adler, Catherine et al. So in 2019, that the title of that was Will Your Patient Benefit from Palliative Care? A multi-center exploratory survey about the acceptance of trigger factors for palliative care consultations among ICU physicians. So it showed only 6 of 24 trigger factors were broadly accepted. That is patient request, 94.2%. Then accepted. Then family request for palliative care consultation, 92% of times. 71.8% of times, no curative options were available. Then 68.5% high and non-manageable symptom burden. 66.5% carcinomatosis or unresectable malignancy. 63.4% curative options rejected by the patients. So the findings suggest potential value in regular screening of patient with the help of 6 accepted trigger factors in this study to reveal unmet palliative needs. So the scope of today's issue is symptom control, goal setting and decision making, communication, and it also involves special issues like care of the patient whose condition is not improving and who are approaching death, end of life care transitioning and management, and bereavement. Coming to symptom management in ICU, 85% of the times there's anxiety. The second most common symptom is thirst. 75% of the times they are tired. However, pain is only 40% of times, delirium 34%. There's also agitation sometimes, sadness and fear 37% of times. Dyspnea is the most distressing symptom. So unrelieved and distressing symptoms present for 27 to 75% of ICU patients. Relatives also shows a high level of symptom distress. Like in 57%, there's traumatic stress. In 70 to 80%, there's anxiety and depression. These are other than physical and emotional symptoms, and they are particularly in the youngest. So the high prevalence of post-traumatic stress disorder among survivors is indirect evidence of the severity of trauma involved for many patients. This was by Davido et al. 2013. So among the key practice points for palliative care in the ICU are issues related to communication, assessment, and management of symptoms and end-of-life care transitioning and management. So these issues are generally addressed through a collaborative process that allows patients or their surrogates and clinicians to make healthcare decisions together, taking into account the best scientific evidence available, as well as the patient's values, goals, and preferences. So this process is critical to defining overall goals of care, and whenever there are fateful treatment decisions that may be influenced by the personal values, goals, and preferences. Coming to the organizational issues for palliative care in the intensive care unit. The Improving Palliative Care in the ICU project has identified 3 main models of palliative care involvement in ICU. The first one is primary palliative care by ICU team. So in this, ICU clinicians address all palliative care needs of patients and families without palliative care specialists. So in this, key features for success are symptom assessment and management, communication with and support for families, shared decision-making with family and interprofessional team. The second type is consultative palliative care by palliative care team. So palliative care team addresses all palliative care needs for all critically ill patients. The key features for success in this is they understand practice and culture in each ICU and to coordinate message for patients and family with ICU team. The mixed approach, which is generally the best approach, in this, ICU and palliative care teams work together to address palliative care needs. The key features for success is to collaboration and communication between 2 teams, identify patients for specialty care based on needs. So what are the practical issues and barriers? If we divide health system into three types: microsystem, mesosystem, and macrosystem. Microsystem involves healthcare providers, patients. Mesosystem involves healthcare organizations, and macrosystem involving health system and policy makers. So what are the barriers for palliative care referral in the ICU? They are mostly personal reasons, institutional barriers, or treatment wish for patients or family. So patient factors are collusion, health beliefs, literacy, religious and ethnoculture factors, individual versus relational autonomy. So in personal reasons, ignorance about legal palliative options, the personal reasons by ICU physicians, like which involves lack of skills and knowledge in palliative care and end-of-life care, in breaking bad news, and in handling distress. Concerns and fears of death, of litigation, of reaction by patient or family. In other emotions, there's always helplessness, sometimes helplessness, grief, guilt, mercy, injured pride. And there's also one hoping for a miracle. The institutional barriers is delay in the establishing prognosis, reaching consensus on needs of family or patient. Then professional ethos and organizational automatism involves bifurcated model of care, fragmented communication, high workload, lack of end-of-life care policy. Macrosystem issues involve inequity in access to healthcare, restrictive policies regarding opioids, limited implementation of the National Program of Palliative Care, ambiguous legal guidelines for foregoing life-sustaining treatments. So a scoping review was done by Christianity and Affinity, the topic of which was barriers and facilitators in the provision of palliative care in adult intensive care unit. So it was done in 2022. So it showed 6 themes which emerged reflecting barriers and facilitators of successful collaboration between the palliative care consultation team and other providers. In this, the primary barriers were attitudes about palliative care, lack of knowledge about the role of palliative care consultation team, and patient and family resistance. The facilitators involved marketing of the palliative care service, education about the expertise of the palliative care consultation team. This paper concluded, for more effective collaboration with other specialty providers, the palliative care consultation team may consider strategies which involve structured educational interventions, increased visibility in the hospital, active marketing of the utility of the palliative care across disciplines. Coming to the major problem, which is communication with relatives. So it is often due to inadequate dedicated time, inconsistent information, which has to always be honest and clear, the provision of information by multiple healthcare providers, and suboptimal communication can also affect the psychological well-being of family members, satisfaction with care, and clinical decision-making. In discussing prognosis, meaningful participation requires an understanding of prognosis. So, additionally, regular decisions of prognosis helps families prepare for the possibility of patient's death. So, discussion of prognosis to be framed in a context of probabilities. Conversation about end of life care should be a part of natural progression of dialogue about the course of an illness and about potential contingencies. Such discussions should occur when considering changing goals of care, whether due to deterioration or due to failure to progress. Even in an earlier stage of admission, transitioning to the care focused primarily on comfort should be introduced as one of the potential treatment goals. In the ICU, most patients are unable to express their end-of-life preferences, either because they are sedated or because their illness is too severe. Rarely, sedatives and analgesics are discontinued in the hope of engaging the patient in the end-of-life decisions. Such attempts are inappropriate when the patient's wishes are known, death is imminent, or discontinuing drugs would cause significant pain and suffering. So then surrogate decision maker has to make a decision regarding end-of-life care. So unless the patient has an explicit written advance directive, surrogate decision makers, usually family members or a nominated healthcare proxy in coordination, are often involved in shared decision-making with the healthcare team. So in the decision-making, it includes the essential clinical issues being addressed, the clinically reasonable choices. The pros and cons of those choices have to be explained. Likelihood of success of treatment and how confident you are in this estimate has to be explained. The surrogate's understanding of the relevant issues are also important. Additionally, it is important to discuss how much the values and preferences of the family, as distinct from the patient, play in decision-making, their opinions, and how the decision may impact the patient's life. Coming to dealing with the conflicts in intensive care. Conflicts regarding end-of-life decisions between families and healthcare providers and between members of the family or between members of the care team are very common. So the most common type of conflicts arise around decisions regarding whether to withdraw or withhold treatment. Such conflicts are often damaging to trust and effective cooperation. From clinicians' perspective, it is polarization of views with efforts to persuade the family that they are wrong, may degenerate to questioning the family's competence or intentions. From family's perspective, the situation is associated with feelings of isolation, misunderstanding, abandonment, doubt towards the integrity of the clinician's commitment to the best interest of the patient. So meetings, that are family meetings to try to resolve conflict is to start by focusing on the common goals of care for the patient and the family. So it is important to acknowledge the emotions that underlie the conflict, which are often distress over the patient's imminent demise. So families need time to come to grips with end-of-life decisions, and sometimes simply allowing the family a day or two to observe ongoing deterioration in patient's condition and to process the information that they received is enough for them to acknowledge a patient's terminal condition. Repeated discussions are sometimes needed if family members do not adequately understand the patient's diagnosis, prognosis, or treatment, even after meeting with the physicians. Bioethicists and social workers may be valuable in helping resolve conflicts. When considering an invasive life-supporting therapy with a limited likelihood of working, it is often advisable to have a trial of therapy with goals of care, with goals and timeframes that everyone can agree on. So that is time-limited trials. For example, in an end-of-life care patient in an advanced malignancy, if he's presented with pneumonia, you'll try to treat pneumonia at least for 4 days. And if there's no response, then you can consider stopping the treatment. Transitioning to comfort-focused care and foregoing intensive care life support, you have to prepare the family members with discussions. Clinicians must assist family through the transition goals and dying process of the patient. They need detailed explanation about the steps that will be taken to ensure patient comfort and also to be prepared for the physical changes their loved ones will likely undergo. The anticipated changes in respiratory patterns should be described as a normal part of dying process. Clinicians should also offer families the opportunity to spend more time with their loved one prior to withdrawals of life support. While this is important, the family must be given to understand that their receiving unusual access requires respect towards the need of other ICU patients. The family is also to be encouraged to meet with a spiritual carer or social worker. To decide for place of care, To extent possible in challenging environment of ICU, the goal is to provide both patient and family a quiet and private space devoid of technology and alarms. So when dying process is prolonged or demands for an ICU bed cannot be met in other ways, transfer to another area in the hospital may be unavoidable. So it is important to prepare the family for this possibility in advance. This transfer should occur smoothly with deference to the needs of the patient and family. Some actively dying patients with difficulty to treat symptoms may actually benefit from ongoing care in the ICU to ensure a comfortable death. Irrespective, every effort to be taken to reassure family members that continuity of clinical and especially comfort care will be maintained. The comfort measures like analgesics and sedatives, availability to rapidly treat distress. This should include infusion of opioids and sedatives, as well as bolus doses of rapidly acting agents to manage any distress. Coming to the bedside of the imminently dying patient, whenever possible, a member of healthcare provider team should offer to be available with the family as the patient is dying. When possible, encourage family participation in patient care. This promotes a sense of comfort, intimacy, involvement when families are in an otherwise strange, tragic, and sometimes impersonal situation. Family members can be encouraged to communicate with their loved one through speech, touch, song, prayer, or music. Caregiving activities can include assisting with washing or hair combing or gentle massage. For some family members, however, being present as the patient is dying is overwhelming, and respect for emotional limits is itself a caring practice. So, in a paper by Zelinsky, Robert J. et al., mentioning impact of palliative care in ICU, system-related, it's significant reduction in healthcare costs, less patient-provider conflict, increased use of hospice resources, and no change in mortality. Then there's better symptom management, the improved goals of care discussions, identification of medical decision makers, reduction in length of stay in ICUs and in hospital, decreased hospital readmission after discharge. It's often clinician-related, efficient implementation of care plans, reduced provider burnout or moral distress, assistance in end of life, and decision-making. Family and patient-related, better health-related quality of life, better end-of-life care, better patient and family satisfaction. A systematic review done in 2017 by K. Adler et al. The topic of which was integration of palliative care into ICU, showed which included 695 abstracts were screened and identified 18 relevant articles, of which 15 were from USA and Great Britain, and 1 was from Austria, Germany, and Switzerland each. So this showed that the palliative care is a meaningful addition to ICU standard treatment. It can improve quality of care and help reduce length of stay in an ICU. And a paper by Yuta Tanaka, saying the topic of which was quality indicators for palliative care and intensive care units, a systematic review. In this key finding, in this 5 studies were included and 109 indicators were extracted. 78% were process indicators and other 5% outcome and 17% structure indicators, in which these all included all 8 domains of National Consensus Project for Quality Palliative Care were covered. The indicators pertaining to the ethical and legal aspects of care were most common, which highlighted the importance of support for ICU staff. This systematic review provides an updated summary for the existing palliative care quality indicators in ICU and paves the way for developing more appropriate quality indicators in palliative care, especially in the context of ICUs. So, in Indian story given by Dr. Kalpana Balakrishnan, a quality improvement process from Tertiary Referral Cancer Institute from South India for initiation of palliative care referral from the intensive care unit for advanced stage metastatic cancer patients. The conclusion of this paper was that structured quality indicator process and introducing the palliative care trigger tool led to the outcome of 50% palliative care referral for critically ill patients in the ICU. And this was an Indian intensive case mix and practice pattern study done in 2016 and 2021. So in this, the 30-day ICU mortality in 2010 to 2011 was 18.1, and which was increased. The 30-day ICU mortality in 2018 to 2019 is 25.3. Also, terminal discharges were 25.1% in 2010 to 2011, and 32.5% in 2018 to 2019. So dying, as Roger Bones said, dying can be a peaceful event or a great agony when it is inappropriately sustained by life support. So the dying patient frequently dies in critical care units. It is estimated that 1 in 5 Americans and 50% of the hospitalized patients die using intensive care. Elsewhere and in India, depending on the case mix that we see, 10 to 36% of the patients are admitted to ICU die. So to develop an ethical framework and practical procedure for limiting inappropriate therapeutic interventions and to improve the quality of care of the dying in ICU through a professional consensus process, Dr. R.K. Mani et al. In 2012 provided the guidelines for end-of-life and palliative care in Indian intensive care units. This was Indian Society of Critical Care Medicine Consensus Ethical Position Statement. And a systematically constructed scoping review done in 2022 by Dr. Seema Rajesh Rao et al., the topic of which was palliative and end-of-life care in intensive care units in low and middle-income countries. So 30 papers reported 19 empirical studies and 2 clinical case reports and 6 discussion papers. And the papers originated from Asia and Africa, primarily using observational designs and qualitative approaches. The 5 areas of research focus were identified, in which first was withholding and withdrawing treatment, professional knowledge and skills, patient and family views, cultural and context, and cost of care. These 5 areas, so it concluded that palliative care in intensive units in low and middle income countries is understudied. Research focused on the specific needs of intensive care in low and middle income countries is required to ensure optimal patient outcomes. And the 5 areas of research focus were identified. So, and a theory of change approach by, again, Dr. Seema Rajesh Rao in 2023 June, in which a stakeholder engagement as a strategy to enhance palliative care involvement in intensive care unit was done. This was the first study conducted in India to identify strategies to enhance palliative care engagement in Indian ICUs. The desired outcome of palliative care integration was good death. So potential long-term outcomes were fewer deaths in ICUs, discharge against medical advice and inappropriate admissions, increased referrals to palliative care, and improved patient and family satisfaction. Coming to Indian Society for Critical Care Medicine is leading an initiative to set guidelines for end-of-life care in intensive care units across India, which has representatives for Indian Association of Palliative Care and other organizations. So the top 10 key messages for today's lecture is: palliative care is relevant for all critically ill patients. Palliative care is the responsibility of all clinicians in the ICU. ICU clinicians can and are obliged to ensure patient comfort at the end of life. A decision to allow a natural death does not itself mean that the comfort is the patient's exclusive goal, or that intensive care interventions should be withdrawn or withheld. Critical illness and intensive care have profound impact on families as well as patients. Palliative care can support ICU clinicians who experience moral or psychological distress in the course of caring for patients. Educational resources and clinical tools are available to support delivery of high-quality palliative care in the ICU. The ICU nurse plays a crucial role in palliative care, including communication between the healthcare team and the patient and family. The quality of the ICU palliative care can be measured, and high-quality ICU palliative care can improve ICU metrics and patient-oriented outcomes. This were given in 2018, the 10 key points about ICU palliative care by Jeffrey D. Edwards et al. So this leads to the end of my topic. Thank you.
Thank you, Ashwini. It was a wonderful presentation, and you have covered all aspects of about the integration of palliative care services, how to start with, what were the barriers, what are the real triggers, and what's happening all over the world and what's happening in India. So wonderfully covered, and we are open for taking the questions.
Number 4.
Ashwini, there is a question. Dr. Meenakshi has said super presentation, but she has asked about clarifying point number 4 in the summary, which you said the top 10 messages. The last slide.
You are on mute, ma'am. Ashwini, ma'am.
I'm sorry. Okay. So number 4 is a decision to allow a natural death does not by itself mean that the comfort is the patient's exclusive goal or that intensive care interventions should be withheld or withdrawn. So that was time-limited trial that we discussed. It's to be applied here, that we have to give at least a trial of therapy. Yes, ma'am.
Can you show that last slide?
Okay.
Can you just share that? So. The last point, third, yeah, second last point. Oops.
Are you able to see, ma'am?
Yeah.
Yes. Raghu, you want to, is Meenakshi, is that clear, or you want?
Actually, my confusion was now given. I mean, using a case, if patient has you have put them on a 48-hour, 5-day time trial, and during the course of your family discussions and with the objective evidence that the patient is actually failing the trial and deteriorating, should we move towards withdrawal of ensuing life support, or we continue and allow natural death? So that's my confusion here, really.
Raghu, you want to take that?
Oh yeah. So see, ideally, everything is based on the communication. So what exactly the goal of the before discussion, before getting into this, the time limited trial. So actually, the time limited trial we usually give for all these patients. Most of the patients do come with certain components of sepsis or certain components of hypotension or something like that, and we give them a challenge of all this a pharmacological treatment to this or a medical treatment to these patients. And ideally speaking, a time limited trial varies institution by institution for 4 days to 7 days. So after that, again, a family counseling is needed. Because if we fail in this time limited trial, and if you don't see any improvement, there are various scores by which we can assess the patients, like SOFA or Apache score, where it includes a lot of laboratory values and clinical conditions of the patients. And based on this, and if we find out that okay, now there is nothing we can do, now the dilemma, now which we have asked the question, is the dilemma. So whether we have to really withhold or we have to just allow the patient to have a natural course of death. So that is a huge dilemma. That's a huge challenge. Even it's difficult to tell. But again, it's based on what we have discussed with the families. And now we also, our Supreme Court has allowed us to really take on to the challenge of withholding and withdrawing the life-sustaining treatments. But again, it is based on the family consensus and the physician consensus, and the board by the Supreme Court, which is told to form 2 boards, and based on that, we can do all these things. But the dilemma is still there. We have not yet done even a single case, even after the January 2023 statement. So we really don't know.
Dr. Sema sir, you said that the legal position is much clearer. Do you want to please give your expert comments?
Thank you, Jaita. First of all, Ashwini, well done. Some of these, points that are that come out of papers from abroad, much of it they can do because of the fact that the bill is paid by somebody else. So that becomes a little more complicated, but be as it may. As far as the legal status is concerned, and what Raghu just mentioned, is that the legal status is clear that if there is a decision that you would like to withdraw life support treatment, there will be two committees. There are two committees. The primary committee will consist of 3 clinicians, including the primary clinician. Once they take the decision, of course, communicating with the family, everything all done, it is then referred to the secondary committee, which will again consist of 3 separate clinicians, of which, now here's the catch, one of those clinicians has to be nominated by the chief medical officer or equivalent of the district or the city where the hospital is. Now, as Raghu said, you have not been able to use this because of the fact that government is not very clear about it. The state government has got to do it. So one of the ways to precipitate that is to write, for example, Tata Memorial can write to, to the Minister of Health or whatever, to say that this is a provision. We would like to know, how do we go about getting the nomination of the chief medical officer for the second committee? So I think that is something that I think you should do. Now, I'm extremely frustrated. I've not been able to do anything in Karnataka. I'm hoping for success in Odisha, where we are opening a second unit. So that's about it. So things are much, much better. And finally, I always tell people, when I talk about all this, that one of the biggest dangers in the ICU is the security guard who stands outside. And he can many times be, very insensitive and shoo people off. I think that is something that we should also, take care of, and probably take communication skills classes for those people also, in how to talk to, the family members who are all very distressed. But overall, I think it's a super presentation. Very well done. Congratulations.
Thank you.
Thank you. Thank you, sir.
Thank you. Thank you, sir. I think I agree with Dr. Kalpana, who says maybe all of us can write, so then there can be sort of collective pressure then, and get the answers. So we do that. Any other? Shobha has said hospital ethics committee PC is apart. Yes, and Dr. Asha has said she agrees with sir's point about the security guard. So that's true. Any other questions? Sorry, Dr. Raghu, you want to say something?
No, nothing. I was just...
Okay. Any other questions before we wind up?
Good morning, ma'am. I'm Nagesh. I'm a volunteer in a palliative care setting. I'm not sure whether this question is relevant to this topic, but is there a role of a volunteer in this setting which you explained so far?
Dr. Raghu, you want to...
Volunteer in what sense? Means whether it's for the communication or whether it is to give just moral support by just sitting there and so there are many roles of a volunteer, right? So even a financial support provides. So there are many things. Yes, they do. I always have a role in palliative care. They are a part of palliative care. That is what I feel, and they also play a huge role. What has been pointed by Ashwini in her presentation. The nurses also play a major role. The volunteers play a major role in this integration. They will play definitely a major role.
Okay, sure. Thank you, sir.
There's one more question. What discussion is held with the patient and family before being put in ICU? So I guess that is going to be the role of the treating team who is going to transfer the patient to the ICU. So whatever is the apt and appropriate communication with that, that should do. I don't think we went about before going to the ICU. We really focused on transition to the ICU and whilst in the ICU. But That is my opinion, but I guess Dr. Ashwini and Dr. Raghu or anyone else can answer that.
Ideally, if you ask me for anything, see, the patients are always referred to a palliative care physician. So for everything, the primary physician is I will say, is the primary palliative care specialist. They have to explain, they have to talk to the patient, they have to give them a disease trajectory, they have to explain them what are the advantages of taking these treatments, what are the disadvantages of taking these treatments, and all these things have to be done by them. See, our role is also there. Even we also do the same thing, but what I ideally feel is that it has to start from them. So that is what should be there. So even in ICU, since the patient has been taken primarily by the intensive care physician, they have to have a real meeting with the family and have to explain them what exactly was the status, why he has come to us, what are we going to do, and what is going to happen. Okay, so that is what I feel is I think the ICU physician is the main stakeholder for giving these opinions in the family. We come maybe when we get a referral. Okay, we directly don't go and just talk or do the treatments, right? So we come when we get a referral, come into the picture. So when we come into the picture, even our role is that we need to discuss with the patients, caregivers or the families, okay, along with the collaboration of the primary care physician. So it has to be always, we just can't individually speak, because everyone has to be on even the primary care physician, and whatever we are explaining has to be on the same page. It can't be different. We are telling something different, they are telling something different. So again, when we come into the picture, there should be a collaboration between the primary physician, the ICU physician, us, and the patient's caregivers or family members. So ideally, it starts from the main caregiver, that is the primary physician, then it comes to us.
There's one more question saying, does the patient have a choice in his own decision making?
Yes, if he is in a state, especially in ICU, most of the patients are not in a state to give their own decisions. But if he's in a state to give his own decisions, they are always a part of the decision making, not the surrogates. That we have to respect that.
What are the outcome measures to show the impact of palliative care in an ICU? I think there was a slide on that, Dr. Manish. So when the recording comes on the screen, on the site, then you might take that. But we did cover that in this, the impact of palliative care. There were some outcome measures. So Ashwini, do you want to? I think we can go through that once more. But we did cover that. The important things when we were preparing this, and Raghu and I and Ashwini, were that we do have, we are in the process of setting up everything everywhere else. Some of our centers like Adyar, Manipal, Delhi, they are setting up, the societies are working on it, and it has to be dependent on our setting, our patient populations, our diseases. So though we can see from the West, we have to always keep our context in mind, and then we can have our own more appropriate outcome measures. So I think we are constantly learning, and that latest initiative that Dr. Ashwini said about the Indian Society of Critical Care Medicine, with other organizations putting up the end-of-life care guidelines, that plays a lot of emphasis on palliative care, end-of-life care, comfort care, however you call it. And so we need to move on. So I think we need to work through that. So I think with that, if there are no more questions, Dr. Raghu, do you want to say some last few words?
Yeah, so definitely this is the future of palliative care integrating with ICU services. And I see there are many hospitals which have come up with their own things, like Dr. Joyita has already said. Though we have certain guidance, it has to be flexible or more molded as per our institution's availabilities and resource availabilities. And I hope that this presentation has, today's presentation has made certain concepts or certain gray clouds clear, and so that we can start working towards integrating palliative care services with ICU care services. So thank you for giving these opportunities. Thank you, Ashwini. Thank you, Dr. Joyita. Cover me up.
Yeah, we have to thank a little later. Dr. Meenakshi wants to ask a question. Sorry, I didn't. Yes, Dr. Meenakshi.
Ma'am, I just wanted to just say that Dr. Raghu has already mentioned this point, especially when palliative care teams are called into the ICU. Invariably, it is the penultimate day before the patient's demise. Sadly, that is still happening. Number two is that seldom, it's not always, but seldom the primary teams are present during the palliative care counseling sessions, which is a great deterrent to shared decision making. Because once the family understands that everybody in the treating team is of the same opinion, it will facilitate decision making, which is not happening as of now. They still feel that we are the only ones. In fact, they don't even know who we are, because nobody is telling them, okay, this is the team who's coming to meet you, and they've actually never met us before. So that's a significant challenge. And also this particular is very, very pronounced in pediatric healthcare, especially with hematological malignancies, because even the primary oncologists are not very convinced that this is patient has reached a point of futility. So these are the 2 points I want to raise. Thank you.
Totally agree with you. So these are the biggest challenges. And I think these challenges we definitely will try to overcome, not maybe 100%, but over a period of time in 5-10 years, I think we can definitely overcome these challenges. It will take time, man. So because even in our institutes, most of the times our oncologists are not in a position to accept the things of futility. They will say, no, we can still give some. So, and another aspect is the peer pressure from the patient's relatives. Right. So they say, no, you give, why are you not giving a chemotherapy and all these things? So now we have come up with a different term called as a compassionate chemotherapy. Right. So all these things are there. So definitely we are going to face challenges when we work, we definitely face challenges. So these are going to happen. This is what his life is. So we will accept those challenges. We'll try to overcome those challenges, and definitely we will move forward. So thank you very much.
Thank you. Dr. Shobha has said that they have combined sessions in ICU at Amrita Kochi. So that's good to know, and we can always learn from others who are having good practice, and because we are always developing our good practice guidelines. So I think we've had a very interesting discussion. I congratulate Dr. Ashwini for a super and a fantastic presentation, and Dr. Raghu for taking your time out even when you're on holiday. On leave, can't say holiday, on leave, for doing this moderation, with apologies from Dr. Sushma because she was not able to join. She was not in Delhi. She was elsewhere and unable to join online. So on behalf of her and the APM, I thank everyone for taking the time and attending this session. Have a good Diwali. Have a good day and have a great week. Thank you very much.
Thank you, everyone.
Thank you. Thank you, everyone, for joining in.